and we'll be doing or completing that in our these two remaining sessions, all the important topics over here. Fair enough. Okay, so let's proceed. So these are all the salient features of the Auricle over here. Here you can see the live classes, the recorded classes, the notes and MCQs. And also we have this packs, basic, standard, and mentorship from 15 to 50K over here. Plus we have this personalized counseling session as well. So be most benefited by this also. Fair enough. So let's start the session over here. And these are the topics that we are going to cover today. Just a second, let me open it up. Here it is, right? Okay. So we are going to start with the scapular region. I will do this highlight over here the important topics, and do listen all of you that these are the important high topics. Go through them, and if you want to take a screenshot wherever possible, you can do that. Okay. And any doubts, write in the comment box. I will try to make it as simplified as possible. These are the important topics, though we obviously don't know that which questions will come, but hopefully questions will come from these topics. Okay. So let's start the scapular region. Scapula, we all know the bone over here, the bone which is the triangular flat bone over here. So the scapular bone is shown. The muscles of the scapular region, these are the major muscles of the scapular region. Okay, and these over here are our deltoid, then supraspinatus, infraspinatus, teres minor, major, and subscapularis. Okay, just let me show you over here. So this from here we have this teres minor over here, TMI, and below we will have the teres major, T.MA.MAJ. Above the spine from here we will have supraspinatus, and from this area we are going to have infraspinatus. Deltoid is a huge muscle, will come from the lower crest of the tip of the spine of scapula plus the lateral border of the acromion process. So from here the deltoid will come. Okay. And other muscle which they are saying is our which one? Subscapularis comes from the anterior of the costal surface. This here done in the bone part. Let's move forward. So question might come on the important notes or a short note on a muscle, deltoid muscle. It's a huge muscle. Now, once you abduct your upper limb, or right or left, which one, and you feel the hardness at the top of the shoulder region, that muscle is the deltoid. You don't have to be very muscular to just feel it, because the muscle is so huge that even a thin person also, normal average individual also, you can feel the deltoid muscle. So deltoid is a triangular muscle, and it's a bulky muscle that forms the rounded contour of the shoulder. You can start the answer like this. Now, remember, in giving a good answer, it's very important that your basics are right. So here we can write, okay, the deltoid has basically 3 parts over here. In just a second. Yeah. Deltoid has 3 parts over here. Remember to write as anterior, middle, and the posterior part. So we have an anterior part, we have a middle, and we have a posterior part. Okay. The middle part are the only multi-pennant muscle. Coming to the actions of the deltoid, that is also very important that we have to understand that the anterior part of the deltoid, right, its main function is flexion and medial rotation. This is a function of anterior part. The posterior part of the deltoid has just the opposite action. It has extension and lateral rotation. It is the action of posterior part. While the middle part, which are the multipinnate, they are the main abductors from 15 to 90 degrees. This much if you know, it's fine. The nerve supply to the deltoid we'll see lower down, but that we also should know is the axillary nerve. Okay, coming from the posterior cord of brachial plexus. So it's coming from the posterior cord of brachial plexus, the axillary nerve. Okay, fair enough. Okay, so insertion, we all know that it inserts where it inserts into the humerus over here. Innervation, as I told you, it's the axillary nerve. Structures under cover of deltoid. Now, whatever structure you can understand, because deltoid is just beneath the skin and superficial fascia. Rest all the muscles, joints, ligaments, bones, they are all under the cover of deltoid. So you can see over here, the bones, you have the humerus and coracoid, they are forming the shoulder joint. Then muscles, you have all these muscles, all the muscles of rotator cuff, P minor also, and a part of P major, T major, and as well as latissimus dorsi, parts of it. Because deltoid is not just present laterally, it is present anteriorly as well, and it is present posteriorly as well. So some parts of P major and T major and latissimus dorsi will be under cover, but mainly it is the muscles of rotator cuff which are under the cover of the deltoid muscle. It has origin of these muscles. Why? Because these muscles take mainly origin from the coracoid process. Okay, coracoid process helps in the origin of coracobrachialis and short head, and long head comes from the supraglenoid tubercle. So they are all under the deltoid. Long head of triceps, they come under the infraglenoid tubercle. Infraglenoid tubercle. Okay. Then it has vessels also, anterior posterior circumflex humeral vessels. If you remember, they were the branches of axillary artery. It has a nerve, axillary nerve, which is supplying it. As I told you, you will have the joint as well as the ligaments, all the ligaments, and few bursa. So joints you have, and you have bursa even. So if that sort of question comes in the exams, how are you going to answer it? If you just write, okay, structures under cover of deltoid 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's better that instead of answering like that, you can answer like the bones, then the muscles, then the vessels, the nerves. So give subheadings like 5, 6 subheadings if you can give vessels, nerve, bones, joints, ligaments, and then just one or two things over here and there. That is itself sufficient. Okay, so it's a way of presentation as I've been telling you from the past 2 or 3 sessions. Last we come over here, how to clinical testing. So obviously it is mainly induced in abduction. So ask the patient to abduct against resistance. So in this person, this you can imagine, this is a person who is being tested over here, right? And this person over here is asked to abduct the upper limb, and the resistance is being given from this hand. The resistance is being given from this side, and the person is asked to abduct the upper limb, and then it is being, the deltoid is being palpated at the top of shoulder joint over here. Okay. We all know about the IM injection, which is being given in deltoid, but just remember that where in exactly deltoid, so it is given in the middle of the muscle, as upper part of the muscle is related to the axillary nerve. So sometimes giving deep IM injection, the axillary nerve might get irritated with the injection. So there's a landmark that should be around 5.5 to 6 centimeter below the acromion process. So you can palpate the acromion process around 5 to 6 centimeter. If you go below it, then would be a good area to give the IM injection. Next come after deltoid is our rotator cuff or the shoulder or the musculotendinous cuff over here. Okay. Now do remember, these are the cuff which are covering or which are attached where to the capsule of the shoulder joint. Why? It is there to protect the shoulder joint. Why? Because shoulder joint is the most common large joint that gets dislocated. The reason why it gets dislocated, see, because the ball is too huge and the socket is very small. So this is the ball, that is a socket. By ball, I actually mean the head of humerus. The head of humerus is too huge. It is actually, instead of, if you talk the surface area, it is 4 times the surface area of the socket that is formed by the glenoid cavity. So the joint is frequently dislocated. So to prevent it, there's a all around there are muscles which blend with the capsule, okay, to make the joint more stable. That is known as our musculotendinous cuff or rotator cuff. So first of all, in the beginning 3-4 lines of your exam or your viva, you should exactly know what is the actual meaning of the question. What does that mean, right? Then you can start our introduction over here. The fibrous sheath functions, as I told you, strengthens it. But here is a point, except inferiorly. Therefore, as you will see, that most commonly the shoulder joint is dislocated anteriorly or antero-inferiorly. Why? Because rotator cuff is one of the main reason is rotator cuff is deficient inferiorly. Next, what are the different muscles that are a part of rotator cuff that also you should know? These are the 4 muscles. Here you can see these are the 4 muscles 1, 2, 3, and 4, which are a part of rotator cuff, which are our subscapularis. It is subscapularis, supraspinatus, infraspinatus, teres minor. You can learn it with a simple mnemonic, which goes like SITS, sits. S, I, small t, and S. This S and I are supraspinatus and infraspinatus. This S is subscapularis. The reason small t I'm stressing, that is why, because it is teres minor, not major. So minor, remember, why small letter. So SITS are the 4 main muscles. You should know their origin insertion. Then obviously, if you talk of subscapularis, supra, infraspinatus, as well as teres minor, they are all coming from which bone? They are all coming from the scapula. Okay, they are all coming from the scapula. Subscapularis goes directly to the lesser tubercle. SIT, all these 3 they go to the greater tubercle. From above below, it is SIT, SINT, right? The nerve supply, you can see subscapularis by subscapularis nerve, both upper and lower branch. Suprascapular nerve, there's also suprascapular nerve, and this teres minor is the axillary nerve. And actions, these are action. There's also action over here. Lateral rotation. Just do remember over here, if I put an additional point, that these 2 muscles, which 2 muscles? The infraspinatus and teres minor. Okay, they are the main lateral rotators apart from your posterior fibers of deltoid. So you can remember it by mnemonic of LRTI. Lateral rotation, T is your teres minor, and I is the infraspinatus. I is the infraspinatus. LRTI, your all lower respiratory tract infection. There you can take the mnemonic. If you want to give a more exact answer, you can also add over here lateral rotation also done by posterior fibers of deltoid, which we have seen already, which we have already seen. Okay. Fair enough. These are the four muscles of rotator cuff mnemonic again written over here. So just go through it again. And just to know how to draw the diagrams, I told you previously, diagram should be clear and labeling should be correct. That's it. That is the only main requirement to draw a diagram over here. Okay. So you can see all these muscles. You can draw clinical anatomy, 2-3 points you can add over here, which are your degeneration of the supraspinatus tendon. Okay, leading to calcification and rupture. So remember, supraspinatus is the most common muscle to be, damaged in case of rotator cuff. Most commonly damaged muscle or damaged tendon is supraspinatus. Why? Because it is actually between the bone below, that is the joint below, and the coracoacromial arch, right? All of that. It is actually sandwiched between two hard structures. So whenever you abduct, and this tendon is proven to be compressed between hard structures, leading to its damage most of the times. Then we have another applied like subacromial bursitis. This is the bursa. Joints are there, so bursitis there. There's S over here, bursitis. The largest bursa is your subacromial bursa, so there could be bursitis, and test for that could be a Dobbin sign. Sign is very simple. You palpate, you ask the patient if they are feeling pain, they will say yes. Once then you ask the patient to abduct. You keep your finger here only at the site of pain, then their pain disappears. That is Dobbin sign. So these 2-3 points in clinical anatomy you can add, right? Then there can be another question of intermuscular spaces. What does it mean? It means, see, once you are doing a dissection, dissections not only mean in anatomy in your dissection hall, but dissection means when you're doing a surgery, you have to do a dissection now. So once you're doing a dissection, you are removing skin fascia, then you see muscles, the bulk of muscles. Then once you're retracting the muscles, you should know that what structures lie beneath the muscles, right? Or between the muscles. That is known as intermuscular spaces and the structures in it. That is the relevance of the intermuscular spaces. Suppose you have to reach, say, radial nerve, right? And you have opened the shoulder, you want to go to the radial nerve. Radial nerve won't itself come out and say, okay, I'm radial nerve here I am. You have to search for it, right? So you have to look between the muscles, where exactly is the radial nerve. I just give you an example, could be searching any nerve or vessel. So here, the intermuscular spaces, they are saying it's the spaces between the scapula and the medial aspect of humerus. Okay, so there are 2-3 muscles which you can easily make. Let me show you the diagrams first, so you understand. Basically, we are dealing with these 3 spaces over here. And these 3 spaces are the spaces around you can say around the shoulder region or around shoulder is fine, or around the scapular region. Okay. These 3 spaces are quadrangular, upper and lower triangular space. These are the 3 main spaces. Now, everything's written boundaries over here, this and there. Don't worry. First of all, understand this is what you can draw in the diagram. So this is which view? This is a posterior view. How, sir, you can say posterior? Because I'm seeing the spine of scapula. Okay, sir. Then few muscles that you need to highlight over here, or you to understand that one muscle is teres minor. Okay, it is going to the greater tubercle over here. One muscle is teres major. You can see over here. Where does it go? It goes into the anterior aspect of humerus. Remember, lady between 2 majors. So this is attached on the medial lip of intertubercular sulcus. Okay, so it goes anterior. This is the second muscle. And between these 2 muscles, the muscle that comes down is the long head of triceps brachii over here. You can see it is coming down. It is actually running between the minor and major. And the fourth structure, obviously, you can see this huge humerus over here. This is a simple diagram that you have to make. Then simply you can say, okay, over here I can see the space, quadrangular space. So what are the boundaries of quadrangular space, if I may just ask? We can very well understand the boundaries. Boundaries are straightforward. This is the quadrangular space. You can see this red color over here. Boundaries are minor above, major below. Medially you have the triceps, laterally you have the humerus. Then you can have an upper triangular space over here. Boundaries are minor, major, and your triceps, upper triangular space. Lower triangular space is this blue color over here. Boundaries, triceps major and humerus. And why are these spaces important? Because of the contents in it. Okay. So this diagram you have to practice 1 or 2, 3 times. To remember this diagram, you can use this simple, you can with this your 4 fingers over here. Okay. So left and right hand written over here. So just this, imagine these, if I go like this, okay, yes. This is teres minor, this is teres major. Minor above, major below. Okay. Then you have this finger over here. Remember, it has to be the long head of tricep. This is humerus. So triceps will come like this and humerus will go like this. Yes, you can see some spaces between the fingers. I may move it like this. These are your quadrangular and triangular spaces, just for your better understanding. The next thing comes that what actually passes through these spaces. See, quadrangular spaces, it is close to the surgical neck of humerus, as you can see over here. Quadrangular spaces close to the surgical neck of humerus. So which nerve should be over here? Axillary nerve and some posterior circumflex humeral vessel. Upper triangular space, it's close to the lateral body of scapula. So here you have the circumflex scapular vessel. Why is that important? Remember, we did a topic of anastomosis around the scapula. The lower triangular space is close to the radial groove. So here you have the radial nerve. Along with it, you will have the profunda brachii vessel, which is the main or the largest branch of brachial artery. Profunda brachii vessel over here. These are the major content. This is all you can give in a tabular form in your exam, suppose they come. So now you know the boundaries, which is forming superior, inferior, lateral, medial boundary, and you need to answer the contents. That's it. This is what you need to answer. So if a question comes, make a diagram like this. Okay, you can make even hand also for, but that is for your basic understanding. You can make a tabular form and you can give the applied part in your own sentence that what's the use of it. Then comes the axillary nerve. Axillary nerve, if you revise the brachial plexus, we touched on the brachial plexus, not in detail, but yes, we touched, though the topic is very, very important, brachial plexus. Herbs, Klumpke's palsy are obviously height. So if you come to the brachial plexus, axillary nerve is coming from dash cord of brachial plexus, medial, lateral, posterior. This is coming from the posterior cord of brachial plexus. Okay, so axillary nerve is also known as circumflex nerve, that you should know. Next thing, we are already, so you have to start like this. Root value is C5, C6. It's a small nerve. It basically supplies the deltoid and teres minor over here and a bit of cutaneous supply at the and on the lateral part of shoulder. That's it. That's it, right? Remember. So, if the question comes of any nerve, you can write a bit of its course. So you know it's the nerve has to come from axilla because there you have the cord of brachial plexus. So you can write cord like this. Even if you don't know the details of it, at least write it has the axillary course. Then we just saw quadrangular space as, so you can, second point, you can write quadrangular space. And third thing I told that it reaches the surgical neck of humerus. So remember, applied part you can add over here that in cases of fracture surgical neck of humerus, there can be damage to the axillary nerve. See, so you have axillary in the course, you have axillary part, quadrangular part, and a surgical neck of humerus part. This is the course of it. Branches I already told you, though it divides into 2 divisions, that also you can write. Anterior division will mainly supply the deltoid, most of it. So most of the anterior division fibers, they go and supply the deltoid. The posterior fibers, they will supply the remaining deltoid and the teres minor. This is the muscular part. See, whenever the question comes about a nerve and you are figuring out what are the branches, even not just theory, but even in the Bible, say like this, so that that the nerves has a muscular branches. Obviously, nerve will be supplying some muscles. Then think of, sir, it is also have some cutaneous branches because as we know that the nerves which supply are mixed nerves. They are sensory, motor, and also sympathetic. Then say, okay, sir, it has some articular branches also. By articular, we mean branches supplying to joints. Suppose there is any joint pain, the nerve will carry the pain. And then say it is giving some vascular supply. Okay. The vessels also need nerves. Why vessels need nerves? Because the sympathetic control, arteriolar dilatation and constriction. So likewise, you can expand your answer. Branches of nerve. So you know the muscle part in case of axillary nerve, you can simply write as deltoid and teres minor. And cutaneous part is on the lateral side of the shoulder. So that is upper lateral cutaneous nerve. And its applied part is known as the regimental badge sign. That is known as regimental badge sign. What is regimental badge sign? Suppose the patient has damage to the axillary nerve. And over here, there will be some cutaneous or sensory paresthesias, right? And that is where the badges are, there's one over here with the regiments of the army or any air force, or that is known as a regimental badge sign. And then you have the articular and vascular, whatever vessels you feel like, you can answer over here. This is how you can answer any nerve over here. Now, regarding diagrams, if you can simply make a part of brachial plexus and show that axillary nerve over here is coming through the posterior cord, that is fine. Simply make a shoulder and show, okay over here that upper lateral cutaneous nerve, upper lateral cutaneous nerve, upper of your arm is a branch of axillary nerve. That is damage to axillary nerve can be damaged. So when can it be damaged? Think about it. So damage to axillary nerve can be an applied aspect. It can be damaged where? In case of shoulder dislocation, which is very common. Then it can be damaged in giving IM injections. It can be damaged. Then we just saw it can be damaged in your surgical neck of humerus fractures. So surgical neck humerus fractures can be damaged. So what happens after damage? You know that it supplies some muscles and skin. So there will be paralysis of the muscle. So the muscle will not able to act. There will be loss of rounded contour of the shoulder. And as I told you, regimental badge anesthesia, you can write that also. Simple as that. Right? This is the step where you can proceed. Okay. And this is what's for the axillary nerve. Suppose any nerve comes, you can answer in that way. Then you come to the anastomosis around the scapula. This we have already done in our what we say, the artery part that we did last time, anastomosis around the scapula over here. Just see the images over here. So they are the various branches which are contributing to the anastomosis. And there's also, you can add a small contribution is by the anastomosis around the acromion process. That also you can add. These are the various branches which add on to it. And do remember to make a diagram of it. So how to make very complicated diagram? No. Only if you know that, okay, which are the vessels which are involved in forming the anastomosis, then the diagram becomes very easy. Why? Because now you have to simply make what? You have to simply make scapula posterior view. Then you can simply make, okay, the artery is coming like this and artery is going like this, and just start to draw some branches coming out from here, which are forming the anastomosis. Simple as. The point over here is the branches need not be very beautiful. The point is these labelings which you are going to do, they have to be correct. That's the only thing. Suprascapular artery should be from here and subscapular artery should be from here. Supra from here. Obviously, this labeling should be correct. Okay. So once you know a bit of theory, diagrams can be made. Okay. So let's see some of the questions over here. Can you label the fibers of deltoid muscle 1, 2, 3? Just see in this image, this question can come. One obviously is moving anteriorly. So one is the anterior fibers, 2 are the middle fibers, and 3 are the posterior fibers. Simple. Then can you label the fibers of deltoid muscle? Yes. Loss of sensation over here. Then match the following rotator cuff muscles with their action. Okay. And there are 3 muscles written over here: subscapularis, supraspinatus, and infraspinatus. Subscapularis, we know that it inserts anteriorly into the lesser tubercle. So it will do medial rotation. Here we can see, okay, one is going with this option. Option number C over here. Supraspinatus, we know it is for the beginning of abduction, so 0 to 15 degree. So it is initiation of abduction. Let me change the color. But this degree over here, it is 0 to 15 degree. Okay. And last not the least, we have what over here, the infraspinatus obviously does the lateral rotation. I told you mnemonic also, you can add over here, which is LRTI. I is your infraspinatus, LR is lateral rotation. Which part of deltoid muscle is multipinnate? We should know the answer was the middle fibers. So middle fibers are also known as acromial fibers. Remember that too. So anterior fibers are your clavicular fibers, posterior fibers are scapular fibers. Middle fibers are the acromial fibers. Rotator cuff is deficient on which side? It is deficient inferiorly. Inferiorly it is deficient. Answer. So these can be good questions. Okay, let's move on to the next topic over here, which is our cutaneous nerves. Superficial veins and lymphatic drainage. They can sometimes come as a question. We'll just go through it. So cutaneous nerves, for basic understanding, we should know that they are obviously cutaneous nerves are there, and obviously we give them as the labels of dermatomes. And we know that in various diseases of neuropathies, in various diseases of the nerves, like your diabetes and your Herpes zoster, anything, any involvement of the nerves, any neuropathies, axonal neuropathies, anything, the nerves will be involved. Cutaneous nerves, the name suggests they are reaching the skin, obviously. So therefore, we are using the term dermatomes. Dermatomes is the area of the skin, you'll see, which is supplied by a particular spinal segment. Superficial veins are the veins which are draining the superficial part of the body, obviously, and lymphatic drainage, we all know. They go hand in hand with our vascular system. So cutaneous nerves, to begin with, that is for your basic understanding, and you can write in the exam or in the Viva. Why do we need cutaneous nerves? We need cutaneous nerves because they are sweat glands in the dermis. They supply the arteries also, and the erector piliform muscles, the muscles which they do goose flash over there, the erection of the hairs of the skin. Okay, so you have these three major functions, three major actions supplying the sweat glands, arteries, and the pili muscle, erector pili muscle. Therefore, we can simply call them as these three functions: pseudomotor, vasomotor, pilomotor. These three. If you remember these three words, you take home message. If you remember these three words, or what is their meaning, that is the best point. Pseudomotor is sweat, vasomotor is vasoconstriction, they are sympathetic, so they increase the BP, so vasoconstriction. And pilomotor is they contract the erector pylori muscle to make the hair erect. Main thing, right? Then obviously we have they obviously will carry the pain, touch, temperature, sensation from the skin. And these are all the cutaneous nerves which you can imagine. So C5 to T1 basically is this. So they are coming from cervical plexus, T2, brachial plexus, 13 SAT, all these different nerves that you can see. So if question comes of the cutaneous nerves, this diagram, not just this table you can't cram all of it. There's no sense of it. But yes, at least try to make this diagram, try to name as many nerves as possible. I will help you to label the nerves. This is the anterior image, that's a posterior image. Let's start the anterior image over here. Okay. So in anterior image, they are showing us this is the shoulder region. Which nerve? Supraclavicular nerve. Root value C3-4. So you have C3-4 over here. Do remember the cycle goes in this direction: C3, C4, C5 to T1. So you will have somewhat around C5 over here, you will have somewhat around C6 over here, C7 over here, C8 over here, T1 over here, and subsequently T2. If you understand just this part, that is enough. Okay, if you go both anterior and posterior. If I ask you that which nerve was this, we have just did a regimental badge sign. This nerve actually was a branch of axillary nerve. Okay, below it, this is the radial nerve as written already. This is the musculocutaneous nerve, M dot cutaneous nerve, and its branches. Posteriorly, if you see, mainly posterior part, you have the branches of radial nerve which are supplying the posterior cutaneous branch of arm and forearm. Medial, if you see, these are the medial antebrachial and medial brachial nerves. These are all branches of medial cord of brachial plexus. So my request is just go through this diagram. I told you the idea C5 to T1, how does it go? Axillary nerve we have seen, musculocutaneous we know, lateral part of forearm. Posteriorly, mainly radial nerve. Medial aspect, we have medial cutaneous nerve of arm and forearm. That is coming from the medial cord of brachial plexus. This is what you need to understand, right? So you remember these three words over here: pseudomotor, pilomotor, and different ways to answer, right? Just practice this diagram. If it comes, not, I won't say it comes, it's very important, but yeah, it might come. This is the only thing I can say. Then cutaneous nerves are upper limb. Now coming to dermatomes. Dermatomes, as we already discussed, the area of the skin supplied by one spinal segment. That's the definition of a dermatome. Remember, there's a lot of overlapping. It doesn't mean if someone you see an X-ray or an MRI, you see, okay, C6 is damaged. Then, okay, C6, I know from here to here to C6. That area will have no sensation. It's not like that. There are a lot of overlapping, you'll see. Okay. Embryological basis of dermatome, that you have to understand that the embryo shows segmentation of the body. You'll see, understand later on. During embryonic development in the limbs, dermatomes are migrated away from the trunk. During this migration, they have carried. So basically, the beginning first lecture I said that upper and lower limb, they are appendages, they are coming out from the body. So when they come out of the body, they obviously will pick up vessels and nerves along with them. This is how the dermatomes have developed. I'll show you an image later on. So important features of dermatome. Upper limb dermatomes are basically your C5 to T1, you have the basically dermatomes from here. And this is the image over here. This is basically not just upper limb, but showing you the areas. But regarding upper limb, the things which you need to remember over here is the tip of the shoulder is C4. I'm telling you the applied part of it. What is the applied part? C. Applied part, that the referred pain is coming at the tip of shoulder from the phrenic nerve. Phrenic nerve supplies what? Phrenic nerve supplies the diaphragm. So any irritation to the diaphragm, the thoracoabdominal diaphragm, referred pain go to the tip of shoulder. And lateral side of arm, we saw C5. Remember, in C5, C6, there can be some spondylitis problems. The referred vein goes to there. And lateral side of forearm, again C6. See, lateral side, I said now C5, C6, C7. So it is going in the dermatome way. So lateral side, we have C5, then C6, and thumb is C6. Remember, very important. That is for testing. We just test this area dorsum of the thumb. You know C6. You are testing C6. Just test the sensation at the dorsum of the thumb, meaning the proximal phalanx over here. Dorsum, not palmar. Palmar skin is thick. Sensation can be best tested with the thin skin over here. Remember, if you want to measure the, just want to see whether the person is having fever or not, you should never touch the forehead with the palmar, or which area of the body with the palmar aspect. No, touch always in the dorsal aspect. Why? Because skin is thin and your nerves over here, they are more sensitive. Okay, so testing also should be done on the dorsal side. So thumb is C6, remember, and little finger is C8, remember. So between thumb and little finger, you have the C7 area. Then you come to the middle side of forearm arm, you have C8 T1. So it is going like this. If you remember, as I told already, this is the lateral aspect, that's the medial aspect. This is C5 as you go down C6, C7, C8, T1 as you go above T2. It's going like this. Axilla, you have T2. Very important, right? Okay. Now these are all the different this nerves given over here. You can take a screenshot of it. I'll just pause for a couple of seconds. You can read it later on if you have better and deep understanding. Ventral primary rami. Now remember that your whole brachial plexus, is, we start with the mnemonic, right to drink chilled beer, then R is right is root. Basically, it is said root, but to be more precise, it is basically ventral rami. It is nothing but ventral rami, which are having the mixed fibers, mixed. When we say mixed, we mean motor, sensory, and sympathetic. That's it. So ventral prime rami, upper limb bud appears on the ventrolateral aspect and supplied a ventral prime rami. They are showing you over here that how does the ventral prime rami, this is the ventral prime rami. Okay, and they are showing the upper limb bud, how it is coming out. So upper limb bud grows out of from the part of the body wall, supplied by the lateral cutaneous branches, okay, of the anterior primary rami of the spinal nerve. Right? So that is your ventral primary rami over here, that how it is coming through the for the upper limb bud part. In the beginning, I said dermatomes you will study, but there's a segmental overlaps. There's a varying degree of overlap. So do remember this practical aspect. There's a varying degree of overlap over here. Okay. Hence, an area of sensory loss following a damage to the cord is always less than the area of distribution. Person might come to you with a C5, C6 injury or compression of the nerves over there, but the sensory loss will be very less because of overlapping. Remember that also as an important part. Now, there are two things over here, effect of limb rotation. Okay, effect of limb rotation. Let's see, when the when the bud was coming out, in upper limb bud, probably the bud was coming out from the trunk, but this bud actually laterally rotated. It actually laterally rotated by around 90 degrees. Therefore, you see your thumb being lateral. And if you look at the lower limb, the great toe of the foot of the lower limb is medial. Because in lower limb rotation, the rotation was actually medially to the 90 degree, medially. In the upper limb, the rotation was laterally. So each developing limb has a pre and the post axial borders. Obviously, the rotation is around an axis. Upper limb but rotate laterally through 90 degree on a longitudinal axis. So thumb and radius be along the pre-axial border. So your thumb obviously, or your thumb or your great toe, it is always on the pre-axial border. It is always on the pre-axial border. Little finger and ulna. So always remember thumb or great toe. They are always on the pre-axial border. This is what you need to remember. Okay. Okay. Pulling of dermatomes, obviously, as a limb elongates, that rotates laterally and gets adducted, pulled away from the trunk. This is trunk. Okay. So this again, I'm telling you, front view C5 to T1. This is the direction C5 to T1 over here. And T2, T3 might come. Axial lines is the line between two adjacent dermatomes that are not represented by immediate spinal levels. Ventral dorsal axis, there is no overlapping. So applied anatomy, just focus on the applied anatomy. That segmental level of the damage to the spinal cord can be determined by examining the dermatomes for touch pin temperature. That is the most important thing. Not just for your writing in the exam or giving the viva, but in your future clinical life as well. You need to know how to test pain touch temperature, and then you need to have a good idea that okay, which nerves the patient is complaining of less sensation. Therefore, I told you, if I repeat again, see, C5 feel on the lateral aspect of the elbow, C6 on the dorsum of the thumb, C7 on the dorsum of the, say, this middle finger, middle phalanx. Okay, C8 little finger or the middle side of the your this ulnar border of the hand. Okay, so C8 over here, T1 again you can feel on the middle side of the elbow. So these are the areas. So that is a clinical anatomy that you need to remember. This is the diagram which will help you understanding. One of the best and easiest diagrams to solve many of your questions is this diagram over here. I'll make a couple of star marks over here. See how the upper limb and lower limb is shown as a growing bud. And see from here, the C2, C3 was over here, C4 was over here, and suddenly C5 went down, C6 went down, C6 went to the thumb, and C7, C8, T1. Then you have the T2 over here. So there is a junction in the trunk. If you see, in the trunk, if you see, you have a junction of C4 and T2. Because C5 to T1 went where? C5 to T1 went to the upper limb. So you have junction of C4 and T2 over here. Same thing if you reach over in the lower limb, L1 you have at the groin region, then L2, L3, L4, L5, S1, 2, 3, 4, 5, it goes like this in the lower limb as well, right? So one of the best diagrams and simple diagrams to understand. Okay. Now let's see the veins draining the upper limb. If you talk about the veins, if the question comes from the veins, you do remember that you have superficial and deep veins. Superficial veins obviously are close to the skin. The deep veins are surrounding the muscles. That's the basic difference. Superficial veins, don't forget two veins in the upper limb, which are the basilic and the cephalic veins. Basilic and the cephalic veins over here. What comes before C, B? Okay, before C comes B, so ABC. So do remember that basilic vein is more medial. If you go from medial aspect, remember, you're going from medial to lateral. First there will be B, then there will be C. Okay, this is how we remembered. So basilic is more medial than cephalic vein, which is more lateral. And it's the basilic vein we have discussed earlier also, that is going to basically form the brachial vein, and that is going to form the axillary vein. And the cephalic vein over here, it's going to drain into the axillary vein. This is the basic idea you should know. Then you'll see the images and understand. So veins superficial and deep, basilic, cephalic. Basilic continues up, and as basilic will go superiorly, it's the lumen increases in diameter. Why? Because more and more blood is coming into it. There are various vena comitantors which are opening into the basilic vein. So basilic becomes brachial and axillary vein, and cephalic vein will drain into it. This is the basic knowledge. Then we'll see the diagram. We come over here, superficial veins. We've seen cephalic, basilic, and that's a new term over here, median cubital vein. But I'm sure you guys are well aware of it. It's a present where in the median means on somewhere in the middle axis in the cubital fossa, and this is the main vein which you do for sampling, which are doctors and nurses and hospital staff. They use this vein for venous blood sampling. It is present right in front of cubital fossa. And why they use this vein? Because see, the base of this vein is formed by bicipital aponeurosis. So this vein is very stable in position. And blood in this vein is basically going from C to B. We'll see in the diagrams. But do remember this vein name over here. If you are not aware, median cubital vein. Remember this name. Deep veins will obviously be the veins which are surrounding the arteries. They are known as vena comitantous. And as you reach the axilla, we call them axillary vein. Why there's no special vein over here? Because this basilic is the one which, as it ascends up, becomes brachial vein. So before basilic becoming brachial vein, there are all these small veins which are surrounding the major arteries. Okay, they are deep because they're surrounding the arteries. Arteries are deep. And then you have the axillary vein, which you have already seen, right? So there's an image over here. At least try to draw this image. Basilic vein medial, cephalic vein lateral, and connecting these two. is this median cubital vein, but that I will like to make a star mark over here just to show you that clinical it is very, very important. Very, very important. Okay. If you must have seen the lab people, if you might have, if you have taken the venous blood on your, with your cell phone, then also, you know, as you might have seen people coming and taking blood samples, right, in case of corona and all, okay, or for any blood testing, people normally use the lab people, they normally use this vein. Fair enough. Now, cephalic vein, to start with, a small question comes from that. Cephalic vein, I told you it's from lateral. So where does it start? It starts from the dorsal venous arch. So don't forget this word dorsal venous arch. On the dorsum of hand, you have a venous arch over here. Laterally, you have this cephalic vein which continues down like this. And from this venous arch, medially the vein that continues down is the, on down I'm using this, but continues up is the basilic vein. So from this dorsal venous arch, the medial continuation is basilic, the lateral continuation is cephalic vein. So from the radial aspect of the dorsal venous arch, that is lateral and communicates later on with the basilic vein through this and that. Okay. But do remember, cephalic means radial end of the dorsal venous network of the hand. This is how it's going to start. Now, later on, you'll see that as the cephalic vein proceeds, now, if I may show you my shoulder over here, look at my deltoid, and this might be the P major over here. This is deltoid, that is P major. This cephalic vein actually runs in the deltopectoral groove. Between the deltoid and the pectoral, this cephalic vein is running. Then as it reaches medially, it then goes through the clavipectoral fascia, pierces the clavipectoral fascia, and then it drains into axillary vein. So this cephalic vein, it does not drain anywhere in the arm or forearm. It will drain where in the axilla directly. After piercing which fascia, let me write its name over here. It pierces the clavipectoral, though it is written over here, but let me write it again. It pierces the clavipectoral fascia. Do remember these points. Okay. Let's see. Most of these are the basic diagrams. You can make a hand and you can make some veins over there. Laterally, remember, make cephalic vein, and medially, remember, make your basilic vein on the medial aspect. And joining these two veins, don't forget to name name and make the median cubital vein. Applied, very important. Okay, again, the same thing, cubital vein, cubital vein. This is showing the heart, the hand over here. Okay, now basilic vein, same. It ascends on the medial aspect. That's the main difference over here. Then it enters deep into brachial fascia at the level of medial epicondyle above. So around the arm, now this basilic vein, which are superficial, it is not entirely superficial. It is superficial only till the forearm and your lower part of arm. Then it enters into the fascia at the level of medial epicondyle, that is just at the level of elbow, you can say, and enters in the at the mid-arm level. Now it becomes deep. Then we start calling it as the brachial vein. Okay. Then start calling it as the brachial vein. You can see over here, this is the basilic vein over here. Let me show this is the basilic vein shown. But see how the color has changed at this area, because now it has entered deep over here, becoming a deep vein, that is the brachial or the axillary vein as it ascends up. In this same diagram, let me show you a few things. Okay, focus on the cephalic vein over here. Okay, look at the cephalic vein. Let me draw a couple of black arrows for the cephalic vein. And focus also on the axillary vein. This will be the axillary vein. I'm making some arrows over here. This is the area where the cephalic will drain into axillary. Cephalic vein will drain into axillary vein over here. Okay, do remember this. Then obviously, as I told, clinically, see, this is the main part. Median cubital vein. It is a large communicating vein which shifts the blood or shunts the blood from cephalic to basilic. So remember, from where to where the blood is going, it is going from C to B, not the other way around. Course is important, clinical anatomy is important. Let's go through these points. These points are very important. Okay, it runs from cephalic vein, goes into basilic vein around the cubital fossa, and you can see over here that's the clinical point of the median cubital vein. Okay. Now let's come to the lymph node. Vessels we have done. Lymph nodes again. It's very simple. You'll see in the notes. But again, questions might come from the lymph nodes. But let me tell you over here that if the question will come from lymph node, it will mainly come from the axillary group of lymph node. That try to understand. So focus mainly on the axillary group of lymph node, which we have done in topic of mammary gland or breast. Okay. So we'll leave the notes for you guys. You can just go through these notes. But mainly you have, okay, over here, yeah, axillary group of lymph nodes. So 5 group. We discussed the groups, how many were there? 5 were there. And we also discussed the levels. There were 3 levels, levels 1, 2, and 3. And what was the key structure that was dividing these levels? It was the pectoralis minor muscle. If you remember, if you have not seen the previous session, all the best. Go through the previous session, you will see all these topics. So don't worry if you are just jumped onto this session suddenly and watching this video, go to the previous videos. You will gain a lot of knowledge. Clinical anatomy, pain along the middle side of the arm is due to pressure of the intercostobrachial nerve by a large gas. So what happens is, this intercostobrachial nerve is a very, very thin nerve, mainly coming from the T2 level. And it runs in the axilla. So it being very, very thin, it might be compressed by the enlarged lymph nodes. Basically, they might ask you which lymph node, then you might answer, okay, central group might be there. Okay, it might be compressed. Okay, so you can write over some questions over here that which corresponding vertebrae for spinal segment, spine of vertebrae. So do remember that at the lower L1, the spinal cord actually ends. Okay. So at the cervical level, just I'm telling you that see what actually is the difference is that this whole, imagine this is the your whole vertebral column from say C1 over here to say a sacrum at over here, right here, the sacrum over here. This whole vertebral column with a black color. Now with this orangish color, these are the nerves which are coming out. So now what happens? See, the spinal cord will end at somewhat over here at L1 region. So this is where the spinal cord ends. This is the spinal cord, and it is ending where at the lower L1 or L1 L2 junction, you can say. So what is actually happening? The nerve which has to come out through sacrum will be going like this, and they form what we call as the cauda-equine. Okay. So suppose now if I say that okay, this over here is vertebrae, say T10 over here. Just okay, T10 over. So at this level of vertebrae T10, if you go inside, then this spinal segment, will it be T10? No, it will be lower down. It will be somewhat around T12, obviously, right? Because spinal cord length is small. It has been contracted. That is a low point, right? Okay, coming to the another question that might come as a small part over here are the 3 names which might confuse you guys: lymphangitis, lymphadenitis, lymphedema. Now see, 1 and 2 are more confusing actually. Lymphedema means swelling. Okay, so there is some obstruction to the lymphatics. So the lymphatics, they accumulate mostly in the lower limb, and there is swelling. So that is simple, lymphedema. So obstruction to the lymph vessel. Okay, this is 3A. Now what is lymphangitis and lymphadenitis? Do remember, inflammation of the lymph vessel. If we say, then it is lymphangitis. So lymphangitis over here, lymphangitis. Remember this point. And how it is seen as a red streaks on the skin. It is seen as red streaks over here. You might see sometimes a patient whose lymphatic vessel is inflamed. They appear as red streaks on the wherever the lymphatic vessel has been inflamed. Inflammation of lymph nodes is lymphadenitis. And this you will see if suppose there is some axillary lymphadenitis over here, patient will complain of pain. There will be redness, there will be hotness over here, right? And this palpation will give more pain. And there will be obviously swelling. That is lymphadenitis. Don't forget it, right? Identify the vein. Obviously, this vein we are discussing right now is the median cubital vein. That is a median cubital vein. Don't forget to go through the topic of cubital fossa as well. It's also a very high topic. Okay. Okay, let's see one more. Okay, arm. Okay, arm we all know has 2 compartments. First of all, from where to where it is the arm, it is from shoulder to the elbow joint with the arm. It has 2 compartments. It has an anterior and a posterior compartment. As you can see over this, is how you can understand anterior posterior. And they have 2 intermuscular septa. What can come in arm is basically not many questions will come, but yeah, they can be questions form of viva, or they can simply ask you some muscles. So as you've seen, there are 2 compartments in the arm: anterior arm, where you have the biceps, posterior arm, you have the triceps. Anterior arm, with the remember 2-3 points. The main nerve over here is musculocutaneous. I'm highlighting this. This is the main nerve over here, and it supplies these 3 muscles: biceps, brachialis, and coracobrachialis. And remember the mnemonic BBC. It's a famous news channel, news broadcasting channel. Okay, so the main nerve is musculocutaneous nerve. The 3 main muscles are BBC over here that you have to understand. Artery is brachial artery, fine. Okay, posterior compartment, the main muscle is triceps, we all know, and the nerve supplying it is basically the radial nerve. Why ulnar also passes through it. So by passing, ulnar will pass median, they will also pass. Median passes anteriorly, ulnar passes posteriorly. But the main nerve supplying the triceps is radial nerve. And the main artery was this. Can you remember that these two structures they're passing through which space around the shoulder? Options are quadrangular, upper triangular, lower triangular space. Think about it and answer. It was which space? It was the lower triangular space through which these two contents were passing. Okay, through the radial groove. So these are the contents of radial groove also. Radial nerve and posterior profunda brachialis. Okay, intermuscular septum in the arm. They might sometimes ask you a rare question, but here is the two septums. Medially septum is this, lateral septum is goes like this. Medial lateral intermuscular septum. Okay, transverse intermuscular septum also they separate some superficial with the deep muscle. Like they might separate the biceps from the brachialis. Okay. Okay. Now there's an here are a diagram which you might practice. It is actually worth practicing. In case of these appendages, upper and lower limb, if you practice the TS transverse section, then in TS everything is shown. Like for example, this TS in between you have the H for humerus bone, right? This is the anterior aspect. That is the posterior aspect over here. Okay. Now focus. Most anteriorly, what you after removing the skin fascia, you see biceps muscle. Deep to the biceps, you have the brachialis muscle. And here, which muscle is not shown is a very small coracobrachialis. Why? Because it ends quite superiorly. It's a small muscle. Posteriorly, if you see three heads of triceps, long needle and the lateral head. Talking of the bulk of the muscle, let me tell you, it is not biceps part, it is the triceps which is more bulkier. Okay. Then these are your various structures like brachial artery, median, all are actually inside. And these veins are two, cephalic vein and basilic vein, they are superficially, so they are more on the outer aspect. And you can also see the intermuscular septum. So if you talk of the sides, then anterior, posterior, say medial, lateral. So here you have the lateral intermuscular, here you have the medial intermuscular septum. So this whole is your posterior compartment, and this whole is your anterior compartment. Okay, anterior, posterior compartment. Right. So remembering to make a TS helps a lot. And medially, you are seeing all this brachial artery and all that you'll see in the cubital fossa as well. That is where you take the blood pressure, right? There's again a diagram of it. Muscles of the arm, again, go through that. If a question comes specifically muscle, do know what you need to write in case of muscle. Suppose any muscle comes, I'm not saying biceps, any muscle comes, you should write few points in muscle, like for example, you should know the origin. I'm not saying every word you should remember, but you should have at least some good idea being in first year exam. Then after origin, you can write the insertion. Okay, then you should know which nerve is supplying that muscle. Okay, then you should know the action of. These are the four major points, and if you can apply it, you can do the clinical applied part of that muscle. For example, how to understand clinical applied. Okay, so these are 5-6 points that you need to know: origin, insertion, nerve supply, action, and clinical applied. Now let me add over here. So how to write clinical applied? If you know the action, think that if the muscle is paralyzed, what will happen? That is the clinical applied. Then think, how can the muscle be paralyzed? Think of this nerve. How can this nerve be damaged? Okay, suppose biceps over here, biceps supplied by which nerve? So the nerve over here is musculocutaneous. So think of a ways by which musculocutaneous can be damaged. If the biceps is paralyzed, then obviously its action won't be done. So its loss of action will be there. That's it. So every muscle origin, I'm just highlighting origin, insertion, nerve supply, action, and clinical applied. Yes, you can add the blood supply as well if you want to add, but not much needed. But these 5 points are must. So by this, you can answer these muscles over here. Then you can make some diagrams if you wish to. It's for understanding. This is the anterior aspect of the arm. The bulk over here, this is the biceps over here. This is the biceps over here. And the deeper muscle is brachialis. Remember that TS which you saw. The superficial was biceps, the deep was brachialis. Okay. Okay, as we move ahead, this is the triceps. Now, triceps will have 3 heads. There's a lot of confusion. That's how to remember 3 heads. It's simple. The long head over here, remember that which we make like this. Okay. The long head this we have is coming from the scapula. Which part of scapula? From the infraglenoid tubercle. And these two heads, lateral head and another head is a medial head over here. They are coming from the humerus. And the nerve that is traversing them is the radial nerve along with the profunda brachial artery. Triceps, what does it do? Extension of the arm and the forearm. Extension at the elbow region and also at the shoulder region. Is mainly done by this triceps muscle. It's a huge muscle. It's a huge muscle having three different heads. And where does it insert? It inserts finally into the olecranon process of the ulna over here. It's a huge muscle, right? Okay, so muscle cutaneous nerve question might come. As I told you previously, also when we were discussing which nerve, axillary nerve. So any nerve, remember the root value, then tell where this nerve began its journey. So you know lateral cord. And remember for this nerve pierces the muscle coracobrachialis, and normally the nerves which pierces any muscle, that muscle which is pierced by any nerve is supplied by that nerve only. So coracobrachialis being pierced by musculocutaneous is also supplied by musculocutaneous nerve. Okay, then it runs downward, terminates where this is important lateral cutaneous nerve of forearm. So over here, this is lateral part of forearm over here, right? There terminates. Of course, if you know the basic from where it is coming and where it is ending, you can easily answer. Do remember over here in the arm, let me point out over here, it runs between biceps and brachialis. So you don't see a musculocutaneous right beneath the skin. So any superficial cut over here, musculocutaneous is preserved. Any superficial cut over the biceps, because musculocutaneous is deep to the biceps. It is between biceps and brachialis. Of course, then relations not that much important. Branches, obviously, as I told beginning, go with the muscular branches, go with the cutaneous branch, go with the articular branches. Okay, and also go with the articular for the obviously for the joints. Can also say vascular branches, whichever artery you can feel is close to it. So it will supply all these areas. Clinical anatomy, damage to musculocutaneous nerve obviously will lead to paralysis of biceps. Okay, paralysis of brachialis. So obviously, if you know what it supplies, motor sensory becomes very simple. If you know the action of biceps, you know if musculocutaneous is damaged, there will be loss of biceps action. Simple as that. Injuries to musculocutaneous nerve, likely site of injury is what? See over here, this point. This is the likely site of injury over here, where it pierces this coracobrachialis at the region of upper end of arm or around the axilla. This is the site where this nerve. Let me tell you that this nerve injury is seen very less frequent. It is not common. It is very uncommon nerve injury, musculocutaneous nerve injury. But you should know even those uncommon things. You have to answer an exam. So it might be injured where it is actually very close to the coracobrachialis muscle over here. And these muscles will be paralyzed. There's loss of sensation around this area. Again, loss of sensation will be less compared to what it actually supplies because of overlap. Right? So brachial artery, this we have done, I guess. Brachial artery is a continuation of the axillary artery. Remember, brachial artery, the first point that should come to your mind is brachial artery. Fine. Oh, we take BP at the cubital fossa, right? So that artery is which artery? Brachial artery, right. You should know this. Then you should know the various branches of brachial artery. Why? Because there are a lot of anastomosis which is occurring around the region of elbow. So you should know the name of branches. The course we discussed when we were discussing the median nerve, if I remember correctly. In the course, I said that this is the brachial artery. And if you look at the median nerve at the region of, say, if I may write this, the axilla over here, and this as the, say, the elbow region over here. Then at the region of axilla, the median nerve was lateral. Then the median nerve crossed the brachial artery. Okay, so remember their what we say, their combination, that median nerve and what is this? Brachial artery. This you should know 3.34 point that should come to your mind. Then if you know the axillary artery, you know where the axillary artery ended at the lower border of teres major. So it will begin at the lower border of teres major. This way to base to right. So if the artery comes, extend here to right. Course here to right, runs from where to where, crosses this joint. It ends at the level of neck of radius. It is a vessel. So you should know from where to where it is and through its course at which structure it is passing. Simple as that. Right? And then you should know its branches, which are very, very important. Brachial artery, course, extent, all these diagrams. Yes. Relations not that much needed. Let me tell you. Relation not that much needed. Okay. Skip the relation part. Come to the branches. But branches. This one, which is Omitted is your profunda brachii artery, or profunda brachii branch. This is the initial branch, and it goes where it goes posteriorly along with which nerve? It goes along with the radial nerve. This is the initial branch. Then there are superior inferior ulnar collateral arteries. Because the artery is more medial, so it gives off ulnar collateral. Then this gives neutral artery to humerus and unnamed muscular branches. All the muscles over there will be supplied by it. Basically, branches, what you should be knowing it. Right? Terminal branch are these two. Brachial artery pulsations are felt or auscultated. There's obviously you do it daily, 100 times you have to do it. Once you reach internship, daily 50 times to take, or 100 patients you take the BP. To stop bleeding from the injury of brachial artery can be compressed. So you should know applied aspect. If there's suppose a cut over here, forearm and hand, there's a deep injury and bleeding is happening. You know it's an arterial bleed. How to identify the arterial bleed? The bleeding pressure is too much. It is the blood is coming out in spurts. So you know there's some artery injury in the forearm or hand. If you wait for some few seconds or few minutes, the patient will obviously collapse. He'll go into shock. What to do? You can do what? You can compress this artery against the shaft of humerus. See over here. Brachial artery palpation. This is the arm region. And the medial aspect of the arm, try to make a tight band or try to compress whatever things you are getting. Try to compress over here to decrease the bleeding at this side. To decrease the bleeding at this side. Okay. Here we have some mnemonics. You can go through them, take the screenshot, right? Learn some mnemonics over here if you are finding it difficult to remember. Okay, so brachial artery. Okay, let's see the last topic over here, cubital fossa. Last topic of the session. Cubital fossa, important topic. So cubital fossa, first of all, it's a hollow in front of the elbow. Over here, it's a hollow. So what things you should know as a first year? Okay, this is the location. What are the boundaries of this fossa? So there are some muscles over here. Okay. Why this fossa is important? One thing we already studied, the median cubital vein going from your cephalic to brachial, cephalic to basilic vein, right? So one thing is median cubital vein. Then deep to or the contents of this fossa, you have MBBR as a mnemonic, median nerve, brachial artery, biceps tendon, radial nerve. So all these are four different important structures. So why this cubital fossa is important? Because of the structures lying inside it. So cubital fossa is a triangular hollow. This is how you can start the answer introduction. Boundaries, you should know exactly where it is. Laterally, you have this muscle brachioradialis, and medially you have the pointer teres muscle, and base you have the two epicondyles. So base is at the top, and this is the other two. This it's like a triangle over here. It's like a triangle over here, right? Apex is below, apex is directed downward, base is at the top, connecting the two epicondyles. Roof is basically what is doing by roof. Roof means the area which is close to the skin. So skin, we have skin, and structures related to the skin will be superficial veins, cutaneous nerves, cutaneous lymphatics. So here you can see they have some bicipital aponeurosis, superficial. You have this superficial vein over here. Okay, superficial vein, which is your median cubital vein. So that is close to the roof part. Okay, floor is where? Floor is deep inside. So if you look at a room, floor is at the roof is at the top, floor is at the bottom. Floor is not the see, it is very simple. Just think of a room. Roof is at the top, floor is at the bottom, and whatever is in the room, table, chair, whatever, that are the contents. The floor is at the below, the deeper aspect. You have a brachialis muscle and supinator. Don't forget these two muscles, they form the floor. Then other things you have to answer. This is how you can simply make the cubital fossa. Okay, lateral side you can make the brachioradialis, and one side you can make a pointer teres. You can connect these, and you can make cubital fossa. Contents very important over here. These are the four major contents. MBBR, as I told you, mnemonic also over MBBR. But do remember what is the MBBR? It is from medial to lateral. Medial artery, biceps, and radial nerve. Four very, very important contents. Then obviously you can make a diagram like this showing us the contents. Okay, this is the medial aspect. Always in diagram in anatomy. Try to write what is medial, lateral, anterior, posterior, superior, inferior, whatever is fit into that diagram. That gives a very good impression to the examiner. That okay, the child knows what is medial, lateral. Then medial, we can write medial nerve, then use the brachial artery, biceps, and the radial nerve over here as a content. So content was a clinical anatomy. The cubital region is important for the following reasons: mean cubital vein, sampling, brachial artery, BP measurement, Vertical flexors of the elbow, right? But these two are worth the topic over here. That was your cubital fossa. Okay, then you have the radial nerve, one all. That becomes more topics, right? So that was all about this session. Tomorrow morning again we'll continue from here and see about other topics. Right. That's all. I hope you guys are enjoying. And the comment box is waiting for you. If you have anything to say, if you're liking or you want anything, any more addition or addition, do post in the comment box. That's all from my side. Thank you for your time. Bye bye. Good night.